Welcome, everybody, here to the forum this evening. I'm Samantha Power, the Executive Director of the Carr Center for Human Rights Policy, and it's a terrific honor and really a privilege to be participating in a panel on the subject of AIDS in Africa. I want to thank Bill White of the Forum for a second year running, creating the space for a community to gather to discuss perhaps the most urgent, wrenching issue of our time, an issue facing thinkers, actors, activists, governments, intergovernmental groups, non-governmental groups, and of course so many citizens around the world. And we're really gratified to see so many people have turned out to hear the discussion. In some ways, I guess we can look at AIDS in Africa from a historical perspective and think about the kinds of disciplines that now have to engage, what nuclear non-proliferation was to the security community a decade or two ago. AIDS in Africa really is to the human rights community, certainly, to development economists, as we'll hear tonight, to physicians, to public health professionals, and to activists all over the world. And we're going to hear several perspectives on this theme, and really looking forward to it. Specifically looking forward to it because the panel and the question for the panel has been posed in terms of solutions or responses. How do we stem the tide of AIDS, and how do we treat those who have already been infected with HIV? And the panelists have been asked to look at this from a multitude of perspectives, from the developmental perspective, from a social perspective. We're going to discuss AIDS orphans, I think, as well as the people themselves who have been infected, and of course as a medical issue. And to start us off tonight, we are very honored to have the director of the Center for International Development here, the Galen Stone Professor of International Trade, and a man who I think is familiar to many of you, Professor Jeffrey Sachs. Professor Sachs, unfortunately, has to leave a little bit early this evening, so he's going to speak first for about 15 minutes, and then each of the other panelists will speak for 7 minutes, and then we'll open it up and hopefully have plenty of time for discussion. Professor Sachs, as many of you know, has research interests that include the link between health and development, economic geography, globalization, emerging markets, transition to market economies, and policy coordination and policy development in developing countries and in the developed world. He served as an economic advisor to governments in Latin America, Africa, Asia, Eastern Europe, you name it. And he's going to discuss tonight the strategies for securing more affordable medicines in Africa to address the crisis. Thank you. Thanks, Jeff.
Thank you very much, Samantha, and thanks to all of you for coming this evening to learn more about and to discuss what surely is the most shocking and heart-wrenching situation in the world, which is a pandemic that certainly rivals, if not exceeds, any killer disease in history. There are tens of millions of people marked for death now, and the numbers are rising at a staggering pace, as you know. The data that the United Nations released in the last few days shows an estimated more than 5 million new HIV infections, almost all in the developing world. And if we continue on the path that we're on, all of those people that are newly infected will die within a few years because they will not have access to care. They will not have access to treatment, to the kinds of drugs that can prolong life and can keep HIV positive individuals alive in rich countries. I want to thank the organizers of this also. This issue cannot get enough attention right now. And for Professor Shelley Lian and student Adam Taylor at the Kennedy School, I give you special congratulations, because I think it's so important that we take every opportunity to discuss this and to try to understand how we can be living in a world in which this is happening and in which there's been almost no response up until now. This is the most amazing thing for me to contemplate, that millions of people are dying every year and we're doing almost nothing still. We're just starting. There's just a cusp at this moment of attention. There's just the possibility that we might actually do something. And it's particularly important, therefore, to try to figure out what we might do if we are given the means. And since I'm an economist, I'm going to talk about the financial means to do something. We have lacked those means. We've lacked the attention to this up until now. To put that in a little bit of perspective, a colleague, Amir Ataran at the Center for International Development, and I have been scouring the databases of the donor world to understand what has been done up to this point in the roughly 15 years in which this pandemic has been unfolding. It's unbelievable, actually. The answer is essentially nothing's been done in scale. There have been thousands and thousands of dedicated workers. My co-panelists are remarkable people, everyone struggling to do something. But in terms of the scale of effort that the world has actually applied, it's something we estimate of perhaps $70 million last year for sub-Saharan Africa, maybe $3 per HIV positive individual in terms of the total donor spending from all of the world to all of sub-Saharan Africa. I hasten to add, one can define the numbers in different ways. There are parts of other programs that could be called AIDS programs. That number that I've just given you is the sum total of funding for programs that are specifically called HIV AIDS control programs. Say it's $200 million, say it's $300 million for a continent that is being ravaged by this disease, where millions of people are dying, where there are more than 10 million orphans, where there are several million new infections every year. The actual flows are absolutely insignificant compared to what is needed and what can be afforded. Next week, the Economic Commission for Africa of the United Nations will hold what I hope will be the start of a rejuvenated African process for defining bold objectives for control and bold definition of needs for financial assistance in order to be able to bring about any kind of humane and sensible response to this crisis. The meeting next week in Addis Ababa will be followed up next spring by what I hope will be an important summit meeting in Nigeria, in Abuja, that President Obasanjo has called, which will follow another meeting that President Obasanjo hosted this past year on malaria, which I don't want us to forget is a killer disease still taking perhaps 2 to 2.5 million lives per year in Africa, also receiving no support internationally to speak of in control. So the problems are vast and they extend beyond AIDS, although HIV AIDS is certainly the most shocking, the most aggressive, the most destructive pandemic that we have seen in modern history and perhaps in all history. When I go next week to Addis, I'll be lucky to have a chance to share some thoughts about what would we do and what should we do and what would we really need in order to be able to meet this scourge with the resources that it requires. And I thought I would share with you in just a few minutes a little bit of the message that I'm going to share with the leadership in Africa and what I see as at least a sketch of the kind of international response that would be appropriate to what is the world's greatest challenge. The first point that I will make is let's not have a competition among diseases. So I do not want us to venture for one moment into a battle between the Stop TB advocates, the Rollback Malaria advocates, the HIV AIDS control advocates. The sheer staggering fact of our world is that there are millions and millions of people dying unnecessarily every year for lack of the resources to keep them alive, not for lack of the technologies, not for lack of the know-how, but for lack of the finances to pay people to implement known technologies. And this involves the three killer diseases that I mentioned: HIV AIDS, tuberculosis, malaria. It also involves other simple technological solutions for killer diseases such as diarrheal disease, acute respiratory infection, micronutrient supplementation, which is so inexpensive as to be shocking that it's not applied, where we still have hundreds of millions of people with vitamin A deficiency and so forth. We need a whole new way of thinking about the rich world and the poor world that understands that the poor world is not just living on the edge of existence, it is falling off the edge, dying by the millions every year for want of a very modest amount of resources that could address this. And HIV AIDS is part of this struggle and part of the problem, but it's not the full definition. And let's not get into a battle of whose disease is worthier. What we need is a new approach that addresses all of them. It can be done. If we are going to address the AIDS pandemic, the next thing that I would urge is that we absolutely understand we need a comprehensive strategy for this disease. The same applies, by the way, to the others that I've mentioned, but each disease is a complex social, biomedical, geographical process that has to be understood in its own terms. For HIV AIDS, we need at least 4 components of a strategy: prevention, urgent; treatment of sick people, indispensable. The idea that you can have a prevention program without a treatment program, which is what the donor world has peddled for a decade, is morally obscene. It also doesn't work practically as well. So we need treatment so that people that are HIV positive go to clinics and can get something there, not just told to go home to die. It makes also no economic sense to allow people to die so that now the world or the communities will bear the burden of raising millions of orphans with all of the social destruction and human tragedy that that implies as well. The third aspect of a comprehensive program is community support. It's not just treating sick people, it's treating communities ravaged by this disease. There are already more than 10 million orphans. There are already huge communities that have been decimated by this disease throughout East Africa and Southern Africa. Help has to go to the communities to hold together, not just to the individuals. And fourth, a comprehensive program needs a research component as well. We know certain things, but what we don't know is vastly greater. We don't know yet how to make a vaccine. We don't know yet on very operational grounds what kind of anti-retroviral therapies will be most appropriate for the viral subtypes or clades of Southern Africa, for example, or under the conditions where compliance is likely to be low, or where testing equipment is likely to be absent, and so forth. There needs to be tremendous learning along the way. That costs money. We have to build that into a comprehensive approach. The next message is that help has to be prioritized. I will urge one order of magnitude. That means at least 10 times, but I am coming closer to 2 orders of magnitude. That means 100 times greater help, and I'll describe where that might come from. But even with that, there will have to be priorities. Prevention has to be well thought out. It has to be serious. It has to be epidemiologically based. There's political correctness in this area, and there's realities also. Realities depend a lot on the specific cultural context in which this disease is spreading. In Russia, intravenous drug use is probably the main epidemiological pump right now of the disease. In many other countries, it's sex workers, it's prostitutes. In other countries, it's migrant labor, men separated from families working in mining areas. And the truth is, ladies and gentlemen, we don't know in most places, not only because it's not so easy to get the community sex lives posted on the internet, nor would you want it there to understand epidemiologically, but because almost no studies have been done in many of the hardest hit places to really understand the underlying epidemiology. Now, I stress this because if you want prevention, you have to understand the epidemiology. One thing that's been learned is that general community education is not sufficient as much as we would like it to be, because in many places in Africa, there's all evidence that young people understand the disease and understand how it's transmitted, but don't change behavior, for example. This is more complicated than simply saying we're going to educate the community. We're going to have to be more clever than that. In some places where sex workers were given condoms and encouraged through peer involvement to insist on condom use, there was a dramatic break in transmission. Thailand is an example of that. And it fit the epidemiological model of the Thai HIV transmission process. By understanding what was really happening, there was a way to get an effective novel intervention that had a dramatic effect, and even the math worked in terms of the basic insight that there are key groups that are absolutely central to the transmission of the disease, and focusing on prevention in that way is critical. Let me just mention that we know commercial sex workers are a critical area to target. STD control arguably is a critical area to target. That is sexually transmitted disease control because of the co-factors involved in HIV transmission. Mother-to-child transmission control through nevirapine or AZT, where remarkably we've known for several years that these drugs can stop transmission from mother to child, intrapartum, postpartum, but there is, as far as we were able to determine, not one single donor-funded program yet actually doing it. So the drugs are there. One of the makers of the key drug, nevirapine, Boehringer Ingelheim, has said you can have it for free, and yet the donor world has not yet started to fund that kind of prevention, the prevention of peripartum mother-to-child transmission. We need priorities for treatment the same way. There are 2 broad areas for treatment. We have Jim Kim here, who's much more of an expert than I, and I will be brief, also so as not to get it wrong. But the 2 points that I want to stress is that I think, as everybody knows, one needs treatment for opportunistic infections, and one needs treatment for the disease itself. Almost nobody in sub-Saharan Africa is getting either, ladies and gentlemen. People are dying of opportunistic infections that could easily be treated, and almost nobody, except for a tiny number of people, is getting anti-retroviral therapy to treat the disease itself. We need both of these. This is really where we need to break the silence, it seems to me. the silence of the donor world in saying, no, we can't afford to save these lives. We can't afford to save the lives because antiretroviral therapy is too expensive. Now, I'll come back to that in a moment. Well, I'll come back to it right now. Antiretroviral therapy at current prices in the rich countries is more than $10,000 per year per person. This is not affordable at scale for the 36 million people in the developing countries, or the 36 million worldwide that are HIV positive. But the overwhelming evidence is that that's not the production cost of the drugs. The production cost of the drugs is not even 1/10 of that, most likely. There is good evidence, it's not even evidence, there is just example of generic makers of these drugs that would provide, at good manufacturing practice, the antiretroviral cocktails for less than $1,000 per year. One of the principal manufacturers of the generics, Cipla in India, has said that with a large enough commitment, it could supply the drugs at $1 a day, or $365 per year. There is no way in the world on any count, moral, financial, economic, cost effectiveness, or anything else, that a 1 year of saved African life is not worth $365. The general standard in the United States is if you can save an adult US life at a cost of $100,000 or less, you do it. So if we can get the costs of heart, that is highly active antiretroviral therapy, down to $365 a year, this is the greatest buy we've got going on every count, ethical and economic. And that's where we're heading if we care to look. The world has not even tried yet. This is what's absolutely amazing, in my view. Understand that heart actually does several things. It keeps a person alive. The second, and that means that not only do you have the person contributing income and sustaining the family, but you avoid the orphans, because they keep their parents, which is a damn good buy for this. The other thing it may do, and this is not certain, but it is quite possible, is that widespread use of heart could actually break the epidemiological transmission, because antiretroviral therapy reduces the viral load within the individual, and it dramatically lowers the probability of transmission in any sex act. And why it's uncertain is that if you keep HIV positive people alive longer, they have more time to transmit. So from a formal epidemiological point of view, it is ambiguous, but there's good reason to believe that heart therapy would not only save lives, save parents, but also dramatically reduce the transmission of the disease itself. So you'd get a triple whammy for this $365 or $500 per year. It could be absolutely the best thing that we do conceivable in the world right now, but the donors up until now have not even been talking about it because they think it's just too expensive, or they don't want to look below the patent price of the drugs. We have major priorities for research. I'll stress, without going into detail, that there's operational research. How do you treat people in specific conditions in specific places? We do lots of operational research in the United States. That's what our medical journals are all filled with. We do almost no operational research in sub-Saharan Africa. And we desperately need to know how things would work in situ, not in theory, but in practice. The other thing we need is basic development research for vaccines, for microbicides, for more cost-effective or more effective, medically effective antiretrovirals. I've mentioned that on top of this, we need community support for orphans and for households where the breadwinner has been has died as a result of AIDS or is very sick and out of the labor force. Now, we're funding this right now on the level of about $70 million a year. The United States is basically doing nothing. Though, for the first time, thanks to an incredible effort of Senator Kerry, our senator, I hope some of you had the chance to hear his remarkable talk yesterday, and he's a remarkable senator. He and Senator Bill Frist together, for the first time, got the U.S. to make a significant commitment for future years for AIDS expenditure, several $100 million, and he's ready to go back for more and to fight for more. But up until now, we've done almost nothing. I was deeply dismayed when President Clinton went to Nigeria this summer, felt their pain, as he's so good at doing, and then announced a $10 million AIDS prevention program for Nigeria, because the only thing I could think about is that if he had stayed home, saved the cost of the trip, he could have more than doubled the help, because a single presidential trip is probably $20 to $25 million. So if he really wanted to help, he would have stayed home, made a phone call to President Obasanjo and said a check for $35 million is on the way. But he didn't do that. He wanted the applause, not the real results, I'm afraid. We need several $billion a year. And it's utterly achievable because we're living, ladies and gentlemen, in the richest time in the history of peoplekind for humankind by such a wide margin that even numbers like billions don't really cut it anymore. We swung around in this presidential campaign what we're going to do with our trillions of dollars of budget surplus one way or another. And we haven't even been able to get billions for this pandemic up until now. To keep everything in scale, the rich world, which is about 1 billion people, 1/6 of humanity, produces about $21 trillion of income every year. So that is 1% of that income is $210 billion, and 1/100th of 1% of that income, 1/100th of 1%, that's a penny in $100. That is $2.1 billion. So can the rich countries afford $2.1 billion a year? That is 1/100th of 1% of their annual income. You're damn right they can. Of course they can. They can afford significantly more than that. We probably should be aiming, depending on what real cost estimates would suggest, at something between $5 and $10 billion a year to properly address this pandemic. It would depend on actual costing, not on gross estimates. But I figure that the World Bank can do $500 million a year, and you'll hear from the World Bank. They are getting their act together in a very innovative way, and I'm very excited about that. The United States by itself could do $10 per American. We could put aside one movie and one popcorn once per year right now out of our $35,000 per person average. That would give $2.7 billion by itself. We're 270 million Americans. And why don't we add in another $3.5 billion from the rest of the rich countries? That would give us more than $5 billion a year from the rich countries that doesn't exist right now. And then I figure we could recycle some of the debt repayments. Why are we asking Nigeria to pay $1.5 billion a year in debt service when its public health budget is only $300 million? And we call this a poverty reduction framework. It's egregious. The more you know, the worse it looks. So there are ways to recycle the debt of a couple $2 billion a year as well. Then the remarkable foundations like the Gates Foundation, which has become the biggest impetus in the world to public health because of the generosity of Bill and Melinda Gates, who have put in more than $20 billion committed to this and are the biggest single funders now of global public health. If we add Gates, Rotary, and others, we could get another $500 million a year. And I figure that the African governments themselves should make an effort. Absolutely. They're desperately poor, they're financially bankrupt, but they should be putting in 0.5% of GNP for their own crisis. And that would probably add in another 0.8 billion a year. Well, I just got you up to $11 billion a year if we need it. It's not so hard. We don't know exactly what we need, but without breaking a sweat in the United States, at $10 a person, we could mobilize through that and through commensurate activities in the rest of the rich world, we could get up to 10 billion if we need it. Of that, my estimate is that you could probably get 5 million people scaled up on HART, on highly active antiretroviral therapy, within the next 3 or 4 years. It won't happen overnight. The facilities don't exist, the doctors don't exist, the training doesn't exist, the operational research doesn't exist. It's not something that can go from one day to the next. But if we did that, that would absorb about $2.75 billion, I figure, if 5 million people are on HART at 50 cents a day, I'm sorry, at $1.50 a day, $1 for the drugs and 50 cents for the cost of monitoring. These are obviously very, very gross estimates. But it all suggests that this is a manageable crisis from a financial point of view if we only care to address it. And that is where I think we are. The final point I want to stress is that we need to rethink not only the money, although I think that's absolutely urgent. We need to rethink quite fundamentally, and I should say even more than that, we need to rethink the morality of this, as I started with, the whole framework of how the rich and the poor are living together, with the poor dying and the rich having more money than they know what to do with. This is another thing that needs some rethinking. But the last thing that needs rethinking very specifically is how aid is actually delivered in general to be effective. My own view is that the United States is actually potentially a lot more generous than it seems. It could not be less generous because you can't go less than zero. And we're essentially doing nothing right now, just scraps. But we would, I believe, do a lot if the American people, for example, that would pay for some of this, could feel confident that the aid would actually work. And we know a lot of aid has actually failed. The kind often when we deliver it to a dictator rather than delivering help through a doctor, when we, the kind that has played so much of a role in giving assistance a bad name. Part of our responsibility, that is African governments, African society, the donor world, and the activist world, if you will, that's trying to do something about this, part of our responsibility is to come up with mechanisms that are scientifically sound, transparent, monitorable, independently evaluated, so that we actually know what's happening with the money. And if it isn't working, so that we can change strategies. And that it's not a pet project of a particular loan officer in a particular aid agency that may or may not have any medical background or epidemiological background, but that it's based on the best scientific evidence, which very, very little assistance these days actually is. So the last thing that I will propose is that the African leaders not only make a commitment themselves to the transparency and efficacy and monitoring and evaluation of a large-scale, internationally financed program, but also that they call upon the donor community to back off from turf battles, to back off from who has the lead name in any particular effort, to back off from the pet projects of particular loan officers, and to create mechanisms in which the scientific community and the public health community can have their strong inputs into what actually works, so that we can have projects designed on the ground within communities that know about their communities. We can have the independent scientific vetting, we can have the evaluation, we can have the monitoring, we can have the ex post assessments, so that the world really can feel the confidence that we're doing something working sensible, worth the effort. Well, ladies and gentlemen, I can't think of anything more in the world that could be more worth this effort. So I hope we do it. Thanks a lot. I apologize for taking too much time, and I doubly apologize that I have to leave. But I want to thank all of the panel as a Harvard person here, to thank you for coming to Harvard for this. And Jim, to thank you for coming from across the way into Cambridge. Good. Thanks a lot.
We'll count the extra 15 minutes as what would have been your question and answer response. No, it was worth it. It was worth the extra 15. Now we have the chance to hear actually about some of the initiatives that the intergovernmental groups and the non-governmental groups are undertaking on behalf of this crisis. In further tribute to Shelley Leanne, who pulled together this panel, you can just look down the row and see that we've got a World Health Organization perspective, a World Bank perspective, a medical perspective, and a non-governmental perspective. And we're incredibly fortunate for that. I'm just going to run down, introduce the panelists, and then each of them will speak for about 7 minutes. And we'll open it up for questions. Sitting here to my left is Naomi Niwatiwa. She's a senior advisor to the United Nations for the WHO's Africa Region Office. And in this position, she represents the WHO at UN meetings, advocating for the inclusion of health in the UN's Africa strategy. And she's going to speak about the WHO's efforts to combat AIDS. Keith Hansen, sitting to her left, is the deputy manager of the World Bank's AIDS campaign team for Africa, which is known as ACT Africa. And he's been centrally involved in the World Bank's efforts on AIDS for the last decade. In the 1990s, he designed and managed the bank's largest AIDS project in the region, and helped shift the bank's treatment of AIDS from that of a health perspective to that of a development concern. He's also been instrumental in trying to get HIV AIDS concerns incorporated into debt relief strategies, which Jeff mentioned as well, and he'll speak about World Bank efforts. To his left is Dr. Jim Young Kim. He's a physician anthropologist and the executive director of Partners in Health, a Harvard-affiliated nonprofit organization that supports health projects in poor communities in the developing world. He's also one of the leading experts on drug-resistant tuberculosis, and he's the program director of the program in infectious disease and social change at Harvard Medical School. He's also recently authored a book, Dying for Growth, Global Inequality and the Health of the Poor. He's going to speak about the pharmaceutical industry and some strategies for affordable medicine. And finally, Ochora Otunu, who's the co-founder and the executive director of the Africa AIDS Initiative, AAI, which is a New York-based nonprofit organization that provides financial and technical assistance to non-governmental groups that are operating in Africa to try to combat the AIDS virus. Before that, he'd actually founded the International Legal Assistance Network, a not-for-profit internet-based consortium of human rights groups and activists that provided pro bono legal assistance to human rights activists. He's going to deliver something of a critique, I think, of World Bank and WHO efforts, and also talk about some of the lessons we can learn from the Ugandan experience, as well as some of his group's efforts in relation to AIDS orphans. So Naomi, why don't you start us off?
Thank you very much, Samantha. Thank you, Shelley. I want to say that I think this is an important meeting, and maybe want to look at what is really happening. The WHO Africa region has been on the ground, and therefore maybe I can give you the latest developments and the other realities probably that are not reflected in the international community. I think briefly I'll sort of summarize, they have the first slide, please, on the scope of the problem, particularly in Africa. This is the 1999. We're having a lot of questions on people asking about the 2000. I think Jeffrey spoke about the fact that the projection of the 2000 statistics is reflecting some around the same kind of numbers, with the situation being still severe in the African continent. The mortality rate in that's the next slide, please. The HIV AIDS in the African continent has kind of changed the population shape. If you are looking at it, if you are looking at a graph, you'll see that it's kind of having a chimney. So it's going to change the way the people look, because the large number of children will grow up without their parents. By the time they finish school, some children will be taking care of their own siblings, and many of these will have to either get out of school and attend to their own relatives. And this has also have a significant impact on the labor market. The other issues that has happened is really how the HIV/AIDS has had an impact on the health sector itself. We're talking of all these kinds of the treatments, the care, the manpower in the health system. We've had serious problems in the sense that particularly in the 7 countries in Southern Africa, that the staff themselves are affected. We lost a lot of doctors, we're losing a lot of nurses, and we're also losing a lot of time, in the sense that if it's a nurse or a doctor, they are themselves attending a funeral, or they are themselves, they are dying. And the staff that is there is overburdened, because the hospital beds, about 70% of them are being occupied by the HIV/AIDS positive. So we have the whole system that ought to be attending to all the other multiple health problems is no longer possible right now to cope with the number with the impact of HIV/AIDS. I would like slide 5. I hope I'm the 5th slide. So to really paint this situation is that, okay, we have a system that is supposed to attend to the welfare of men, whether it is in research, whether it is in treatment, or whether it is in the hospital services, or the manpower, or everything. That whole system has caved in, and this is the reality of it. And it has caved in a very, very complicated situation of whereby we are concerned on the capacity to cope with all these other problems, how will it be managed from here. So what WHO has really been doing is trying to strengthen the health system. But even that, it is still quite difficult. And then they're also trying to look into the area of prevention care, as has been said, and also to monitor the epidemic of the disease. And on the second, that's number 6, please. On the promotion of the evidence-based care, the WHO is looking at the testing, and it's also looking at the including of the prophylaxis for the common HIV-related diseases, and the nursing care, and the psychological support, including the referral mechanism. The other, next please, the other thing that we're looking at is access to quality of antiretroviral drugs, and I think that has been taken care of, and I will not go into the details. The second slide, please. The other developments that have taken place, probably this one is not mentioned, is that is on the traditional medicine. I hope it's on. Is it the traditional medicine? Okay, that's slide number 8. Sorry. Okay. It's on the traditional medicine. Sorry. Okay, so I just go on. It's difficult. But what has happened so far? We found out that 80% of the African people in the rural areas depend on the traditional medicine. So with all this impact of HIV/AIDS, the people have themselves been kind of taking some kind of leaves, roots, or whatever they have been taking. But what has happened is that WHO has been monitoring some of these cases, and they found out that there are real cases of where these traditional medicines have made an impact, and has actually reduced the CD4s in a lot of patients who were actually being expected to die within a short time. So WHO is now working to support this and to look into the ethics and the conduct and the training of manpower. Since the HIV AIDS has been in the international world, particularly more in the last years, there seems to be a lot of difference between what really takes place in the meeting and what the resolutions that have been passed, and the real realities at the ground. As I said, that the health system itself is caved in, and the doctors and nurses are dying. So the care really that is taking on, that is happening, is becoming very difficult. So we are in a situation in the African continent of where there's a sweeping problem of, even we talk of counseling, people can no longer counsel because they themselves need counseling. I just want to give you an example of the kind of dyings that are taking place. You know, there's a very typical case that we know of is an old woman who buried 8 sons in 1.5 years. And all these 8 sons had children. When the seventh son died, I participated in that funeral. It was very painful because I saw the woman wasn't doing very well. On the 9th, when the 9th child died, the old woman had a house full of little children. She died 1 week later. So we have a kind of phenomena that I would like to say it is not being paid attention to. Is we are saying that they are orphans and they are old people or their grandparents that are supposed to take care of the children. And no study has been done to see the health situation or the health condition of the grandparents that are supposed to be taking care of the children. So we are assuming a system, in fact, that the children are being taken care by their grandparents. Maybe it's not as good as is saying. Then we also have other situations, the situation of the orphans themselves. We haven't done enough studies of what is the process that these orphans have gone through that has resulted in their being an orphan. In other words, I know very many situations of where children eventually, because the other relatives have died, were found boiling leaves and trying to force it down their mother, the liquid down their mother, because they're afraid that now mother will die because the rest of the people in the village have died. We also, I can just cite one very prominent case of where all the relatives had died or they were very busy, but this woman with the 3 children ranging 7 months to 6 years, went to the hospital, and the hospitals now, they cannot take care of you when they see that you're going to die. They give you a little medication and send you back. They send her back, and she went into a room with her 3 children. People were very busy, burial, funerals, etc. She died. And nobody paid attention for 3 days. They finally found they were attracted to where the woman was because of the smell. They found the woman dead for 3 days with the 3 children sitting around. These children have been taken into the orphanage. Now, we do not know, the point here is, we do not know the experiences the children have gone through to become orphans. We can talk in general of orphans, but what is the process that they have gone through? And eventually who will heal these scars that have gone on? And what is the health situation? What is the health condition of these children? We have an orphanage in Harare that the WHO has been supporting. We found out that of the over 100 children that were there, about 90% of them were HIV positive. However, this is something that has happened was that with the improved nutrition and the care, about a good number of those children have been retested again and they've tested negative. These are other developments that one could look at on how to improve the situation. So we were asked to comment on our own points. My own comments is really, I think we need to look a little bit deeper, and we need to look into the real dynamics that are taking on place, so that the strategies that we are proposing are going to make an impact, and please, there's definitely a sense of urgency. I think I should stop there. Thank you.
Thank you, Naomi. Next, we move to Keith Hansen of the World Bank.
Thank you very much, and thank you for that very moving presentation. I have 7 minutes to explain the relationship between AIDS and development and what the World Bank is going to do about it. So I'm going to try to be very brief, and forgive me if I leave things out. I'm going to focus on the big picture here. I was asked to explain why the World Bank cares about AIDS, and the answer is very simple. We have one mission at the bank, which is stamped in concrete in the entrance of our headquarters. Our dream is a world free of poverty. And until the world is free of AIDS, our dream is going to remain only a dream. What you've just heard is the catastrophic impact that this pandemic has had on this first generation that it has hit in Africa. The problem is, the tragedy is, it is already undermining the future of the next generation. It's threatening not only to kill people today, but to undermine every aspect of development that promises a future for the next generations. I'm going to give you a few numbers here. I won't belabor them. We could talk about other issues later if you wish, but to me, these are the most striking. First of all, the prevalence rates you hear are unbelievable enough, 25, 35% of the adult population. But you have to realize what that poses is a repeated risk of exposure to the next generation that is just starting out in its sexually active life. UNAIDS estimates that a 15-year-old today in Ethiopia has a 40% chance of contracting HIV in his or her lifetime. In Zimbabwe and South Africa, a 60% chance. And in Botswana, an inconceivable 75 to 85% likelihood of getting HIV. This next generation is standing on the precipice of absolute disaster. Now, this is on current trends if we do not move more quickly than we have. Life expectancy, which rose more in the 40 years after World War II than it had in the 4,000 years up until that time, has already plummeted by 10 years or more in many African countries. And in some, the US Census Bureau estimates it could drop to 30 years within the next 10 to 20 years. Life expectancy has not been 30 in Europe for 1,000 years or more. Life expectancy is not only the most sensitive and best composite outcome of the quality of life in a country, but it is also an important contributor to the quality of life, because it has a large bearing on how much people invest in themselves and in firms, whether they stay in school, whether they send their children to school, whether they think there's a future to plan for or not. Next is the orphans. There are already 12 million orphans in Africa alone from AIDS. In 10 years, there will be 40 million. This is absolutely without precedent in history, so far as we know. Not even in the Soviet Union at the end of World War II was there a share of children living in orphanhood of that nature. This is the greatest social welfare challenge that Africa, or probably any country, has ever confronted, and this is the poorest region of the world. Growth is also going to be affected by this. It is devilishly difficult to pin down the impact on growth of the disease, but there are a number of estimates from different sources using different methods that all seem to converge around the idea that AIDS is probably already costing Africa close to 1% of growth per capita per year. It doesn't sound like a large number, but bear in mind that in the last 3 years, per capita growth in Africa has been 1.2%, and these are the best 3 years in a generation. In countries like Zimbabwe, the impact is probably 2% or more. A very detailed model of the South African economy, where we have good data both on the economy and on AIDS, suggests that in the next decade, AIDS is literally going to change the trajectory of that country's future, from up to down. The economy, instead of gradually growing up to a fairly robust rate, is going to start shrinking, even in per capita terms. 10 years from now, per capita GDP will be 8% smaller than it is today because of AIDS, according to this model. This means that a country that has the greatest inequality on earth is going to impose 8% more poverty on the people. Their consumption is going to fall even more because of those who are alive. They're going to be spending more money on palliative treatment and care and support for those who are sick. this is a loss that Africa cannot afford. Growth is not everything, but if the resources are not there to fund this, it's going to undermine development severely. And so our view in the bank is that AIDS poses the paramount threat to development in sub-Saharan Africa today, and an ominous and growing threat in the rest of the world. We do not believe AIDS is simply a choice among other competing demands for investment. That is a false choice. This is a precondition for investments in any other sector to succeed. What is the point of building schools if you haven't calculated how many teachers are going to be left in service 10 years from now? What is the point of building highways if there isn't going to be the road traffic to sustain them and pay for themselves? We have a slide that we show to finance ministers and very high policy wonks, and it's extremely simplistic. It says there are two policy options: pay now or pay a lot more later. This is the single most important investment that Africa can make. So what is the World Bank doing about it? We were late. Like the rest of the international community, the bank came late to the AIDS cause. We are one of the two biggest funders since the start of the epidemic, along with the United States. We've probably provided about $1 billion to more than 80 projects in dozens of countries all around the world. But as Professor Sachs said, we did not make the effort in scale that was required. Particularly in Africa, by the late 1990s, it was clear to us that we were failing and that we were going to fail unless we took a radically new approach. So we looked at ourselves, we looked at what we were doing, and we realized that there were a number of problems we would have to overcome to stimulate a broader response and more demand. And this started with advocacy. The bank has a tremendous amount, perhaps too much, influence on the policy agenda in development. And we realized that we were not using that bully pulpit to explain AIDS as a development issue, not just a public health crisis, not a social humanitarian crisis alone, but a development disaster that had to be taken on. And so we have radically stepped up the amount of attention that President Wolfenson, our vice presidents, our policy statements give to this. We put it in our meetings with African heads of state. We put it in our presentations and our research. We are putting it into debt relief. We're putting it in every place we can because it belongs at the center of the development agenda. Secondly, we had to build up our own capacity to deal with it. Like most organizations, we had addressed AIDS as a health issue, and we cannot solve this pandemic through the health sector alone. It is too great a problem. And so we began with all the tools we could. We started retrofitting our projects. Wherever there was an opportunity to spend idle resources or use people to forward an HIV/AIDS message or tools, we have been building that in. We've been making AIDS one of the priorities for uses of the debt relief under the HIPIC initiative and under the poverty reduction strategy. We've taken a multi-sectoral approach. A special team was established, which I'm the deputy, and Dr. Deborah Work-Zowdy is the head. This is a multi-sectoral team that sits right under the office of the vice president. We're not part of the health unit, and we're approaching this in a multi-sectoral way. We've built in safeguards to all our projects to make sure that they do not inadvertently contribute to the spread of HIV. If you build a 1,000-kilometer road and you take hundreds of men away from their families for months on end, you're asking for trouble unless you have prevention and mitigation means in place. Third, we had to start contributing more to the knowledge base. This means calculating, to the extent we can, macroeconomic and sectoral impacts of the diseases, contributing to vaccine research. We're a co-founder of the International AIDS Vaccine Initiative. We've put a lot of analysis into the market failures and imperfections that are preventing a vaccine from coming to market more quickly, and contributing to research in things like female-controlled microbicides, so women can take more control of their own destiny in this regard. And finally, of course, resources, money primarily, but also broader partnerships, and work with the drug companies to try to bring the prices down, and work with our UNAIDS co-sponsors and the Joint United Nations Program on HIV/AIDS, of which WHO is a founding member, along with 5 other UN agencies. If we don't contribute the resources and the people to this, we're not going to make a difference. This has culminated in a very broad approach, which is spreading every day in the bank. But for Africa, the most relevant outcome has been what we call the Multi-Country AIDS Program for Africa. This was approved by our board just over 2 months ago now. It provides $500 million for countries in Africa to use to implement their own national HIV/AIDS strategies. The problem of AIDS in Africa to date has been that not enough governments have taken the lead, shown the courage that Uganda did, developed their own strategies, and said, this is what we mean to do, and you are either with us or you're not in this game. More and more countries are doing that now with their own strategies developed in a participatory way with people in those countries, the public sector, the private sector, persons living with HIV/AIDS, civil society, to push forward on one common front. We are trying to make this money available as quickly as possible. We have radically cut down on the preparation time, our bureaucracy, our procedures. With any luck, we should have 12 countries and $500 million moving within 9 months by the end of this fiscal year. In the 4 years leading up to this time, I don't even want to tell you how little money we were able to move into Africa. Not for lack of desire on our part, but for lack of a mechanism and, frankly, for lack of interest on the part of the countries. We are finally seeing this groundswell come up. The principles of this support are, first, government and national ownership. These have to be nationally owned programs and driven. We have no agenda of our own. Secondly, the money is comprehensive. It supports the entire range of prevention, care, support, and treatment. Whatever is appropriate, whatever is provided for in that strategy, we will support. Third, it's built on a strong base of partnership with our UN AIDS co-sponsors, with the International Partnership Against AIDS in Africa, with anyone who's willing to contribute to that. And fourth, there's a special fund in each of these programs to allocate money directly to communities and to non-governmental organizations. When the history of this epidemic is written, NGOs are going to be the heroes, because for the first 15 years, they mounted all the campaigns, they did almost all the research, they did all the results that have proven that we are now trying to take to scale, and they were the ones caring for the people, the millions who were falling sick while the world was not responding. They deserve a share of these resources. Communities need to be able to take care of their own response. So this is a brief summary of what we were doing. 40 years ago next month, the man in whose honor this school is named inaugurated an era by calling for a grand and global alliance against the common enemies of mankind: tyranny, poverty, disease, and war itself. For his generation, inaction in the face of tyranny and war had proven a very high cost. For us, passivity in the face of poverty and disease has provided a heavy reckoning. Today, with UN AIDS, with the international partnership, with the renewed resolve of the public and private sector around the world, we have at last the makings of that grand and global alliance. The World Bank is going to do its part, but we cannot do it alone. We need everybody at this panel. We need all of you. This will be the crucible of development for the next generation, and we are going to do our part. Thank you.
Thank you. Our next speaker is Dr. Jim Young Kim from Partners in Health and Harvard Medical School.
Great. Next slide, please. I want to look at a particular example. And first of all, this is one of the most incredibly well-organized things I've ever attended. I would just say, though, that to think that the people from the World Health Organization, the World Bank, and 2 directors of NGOs would speak for 7 minutes is, I think, a little bit wishful thinking. But let me go through a very specific example. And I'm going to look back at least 2 years. But what I would like to suggest is that the people who've said that it's just too difficult, it's just impossible to bring the prices down, it's impossible to organize these programs in developing countries, I would like to provide a particular example and suggest that we can do better. In the disease that I want to talk about briefly to begin with is multi-drug resistant TB. This is by definition tuberculosis that is resistant to the 2 most important anti-tuberculous medications. We encountered an epidemic in that little town of Caraballo in the northern cone of Lima in 1996. At the time, the World Health Organization, quite literally under the boot of the World Bank at that time, to keep the cost of its interventions as low as it could possibly be, argued that multi-drug resistant TB was untreatable, and it argued that, one, it was too difficult to treat because of the complexity of the intervention, very similar to the arguments that you're hearing today about intervening in HIV. And 2, the argument was that the cost of the drugs was far too high. And they essentially, at the World Health Organization as recently as 1998, had declared a death sentence on all who suffered from multi-drug resistant TB. We're not clear what the percentage is exactly of those patients, but it's probably 1% of all TB sufferers, and TB is still among the leading killers, infectious killers of adults. It kills about 40% of all HIV patients who die. It is a very serious problem for HIV-infected people. So the WHO in '96 made very clear remarks about MDR-TB. If we started throwing MDR-TB into the mix, the cost of intervening on TB would go too high, and the World Bank, as part of their cost-effectiveness analysis, would have declared it not applicable and sort of out of the range of what developing countries could expect. As you can hear tonight, the attitude is entirely different at the World Bank, and we are now working closely with them, in fact, on trying to stem the tide of this epidemic in Russia. Next slide, please. The argument was that the price of the drugs were too high. And when we met in 1998 with the World Health Organization, they told us that, well, the drugs are too expensive, forget it. When we did a very little bit of analysis, we found that all the drugs were generic. And what was happening was, because the WHO had declared it untreatable in poor countries, there was essentially a branded situation. There was one manufacturer for each of the drugs. So generic drugs were acting like branded drugs, partly, and we think mostly, because the World Health Organization had declared it untreatable. So we argued that with very little activity, we could probably bring down the price of these drugs. And at that time, I argued that we could bring down the price of the drugs 95%. And throughout the public health community, I was told that I was absolutely crazy. Next slide. Well, we started treating the patients anyway, because what we had to do was develop a model. We had to first show that MDR-TB, which is a 2-year-long treatment process with very toxic drugs, not dissimilar to cancer chemotherapy, but for 2 years because of the difficulty of using the drugs, we jumped in and we knew that we had to do first treat the patients successfully in order to begin thinking about bringing down the prices of the drugs. Next slide. The World Health Organization, though, in 1999, still were saying to us, you're causing problems, you shouldn't talk about MDR-TB, because what that will do is raise the price of our overall intervention and maybe take TB off the map in terms of what would be recommended by, in this case, the World Bank. Next slide. Well, we treated the patients, and in our first cohort of 50 or so patients, we had an 85% cure rate. This was unheard of. People couldn't believe that we were working in a shantytown community and got 85% cure rates. Dr. Howard Hyatt here, former dean of the School of Public Health, actually called in his former students who were leaders in the global TB world and practically forced them to come to this meeting. And at that time, next slide, please. At that time, the World Health Organization changed its policy, and they said, well, at least we know we can do it. But at this meeting in April of 1998, what they still told me was, you can do it, and maybe you can do it in special situations, but the cost of the drugs are too high. I spoke with 4 different representatives of the Global TB Program and asked them, but you know the drugs are generic. And it turns out none of them knew that the drugs were generic. So they had declared a death sentence on these patients without even having understood that the drugs were in fact generic and prices could be dropped precipitously. Much to the credit of WHO, they started working very closely with us immediately and took on this cause with great energy. And what we realized that we had to do was both lower the price and increase control. If second-line anti-TB drugs are available everywhere for very low prices, what will happen is that people will misuse them. It's very difficult to get people through a 2-year-long treatment, and what you have to do is directly observe every single dose and treat side effects. So we came up with a model that was sort of out of thin air. We'd heard that with meningococcal vaccine, they had formed something called the Green Light Committee. So we formed our own Green Light Committee. And this was an effort that was done very quietly. It never reached the level of attention that HIV has reached. And that was helpful to us because they thought that we were doing something that was sort of silly and irrelevant. Next slide. Well, this Green Light Committee, by negotiating with the research-based pharmaceutical industry and also negotiating with the generic drug industry, has been able to realize decreases in prices of 85 to 95%. And this happened in 1 year. Next slide. I'm really going to try to stick to 7 minutes. In Brazil, many of the patents are not valid in Brazil for HIV drugs. And for the drugs that have a single maker, prices have not dropped much. Next slide. But for those drugs that are generic, even the generic drugs that are freely available in Brazil have dropped precipitously in the last 4 years. Next slide. Indeed, when you look at the US price and the cheapest available price in the world currently, we're talking about anywhere from 70 to 80 to 95% differences in the price of these drugs. Next slide. Cipla, the group that Professor Sachs spoke about, has offered to sell D4T for 10 cents a pill. And you can see what kind of a reduction in price that would represent. Next slide. Are there mechanisms in place by which governments, for instance, could argue that drugs for Africa should be offered at 95, 96, 97% reductions. Well, the law that really facilitated the movement of NIH-supported research, the fruits of NIH-supported research into the pharmaceutical industry actually has caveats in there that says if the drugs aren't developed quickly by the company, or if they're too expensive, and if they're too expensive and and there is an emergency of some sort, well, the government can demand what's called a reasonable cost, and reasonable cost is undefined, but in other words, even within the United States government, there is a mechanism by which NIH and other government agencies could demand lower prices from corporations. Next slide. These are the drugs that we know of that have received support by public bodies. Next slide. We also know, if you look at the profitability of the global pharmaceutical industry, the so-called research-based pharmaceutical industry, the profits are absolutely extraordinary. One company, Merck, which had the highest profits in 1999, had a net profit of $5.9 billion, which is more than the top 9 airlines combined. Their combined profit was $4.6 billion. Now, I say this because Merck and other companies have expressed a clear interest in responding to this crisis. And if anyone would know the willingness of these companies to participate, it would be Professor Sachs. And he thinks that the pharmaceutical industry is simply looking for a vehicle by which to put these drugs into the hands and the mouths and the bodies of HIV-infected people. Next slide. Just to give you a sense of scale, and this is what Professor Sachs has brought that's been so important for the public health community. India and China together spend about $29 billion on health, which is less than what Massachusetts spends on health. 10 years ago, when the CIA, that wonderful advocate for public health, told all of us in its white paper that you better respond to HIV now. It's going to cost about $3 billion a year, and you better do it now, or there's going to be hell to pay. And indeed, they said it will become a national security threat if we don't respond. This was 10 years ago. Well, the public health community threw up its arms and said, $3 billion, that's just totally unthinkable. Bill Foege, who's now the senior advisor to the Gates Foundation, at that time said, but we have to remember that's what we spend on health every day. Next slide. I just want to tell you a brief story. Adeline Marcone is one of our patients in Haiti. She was HIV positive for 10 years, and she'd lost more than 80 pounds over that period of time. Her father came to us and asked for money for a coffin. Next slide. Instead, we gave her triple therapy. She's gained more than 20 pounds. I can't even read this. And she was the first patient in our Health Equity Initiative. And we're HIV Equity Initiative. And we treated her with medicines that were donated by Cambridge Cares About AIDS. One of the incredible realities of our world is that Harvard medical students, when they go to Africa, are required to take with them a 1-month supply of triple therapy in case they have an exposure. So we thought that that was a little bit of an overkill, but we also got them to agree that every time they came back and they hadn't used these pills, they would give them to us and we would send them to Haiti. Cambridge Cares About AIDS, every time a patient changes from one medical regimen to another, we get the old medicines and we send them to Haiti. And our patients have done extraordinarily well, and they've done well without doing CD4 counts, without doing viral loads. And we would simply argue that all the naysaying about lack of health infrastructure is not it's not just unrigorous, which it is unrigorous, but it's also deadly. Next slide. Next slide. That was actually Dr. Sachs's description of what needs to happen around HIV control. And we think that what he has been pointing to is a green light committee for HIV drugs. Now, what you'd need for a green light committee is you'd need a model of how to do the work. And we're actually doing it in Haiti, and we think that they're developing that model in Brazil. Now, we're doing it off donations, and we don't have a penny for our work in Haiti. So if any of you, I'm an MGO director, so if any of you are interested in donating, you can come talk to me later. I can't, I'm sorry, these were really great points, and I can't read them. Technical support, a cadre of experts. We've already done this, and we've modeled this with our Green Light Committee for MDR-TB. We have experts from all over the world who are ready to fly to countries or programs that want to treat MDR-TB but don't have the technical expertise. Instead of saying, oh, well, gee, you need the technical expertise, what we've decided to do is just aggressively move toward providing the technical expertise. You need agreements from pharmaceutical manufacturers, and we think that that is ready to happen. You need a source of funding for purchasing these medications. We've been working with the procurement people at the World Bank, and they're very interested in looking at this model of procurement where you have an expert body that negotiates directly with the companies, holds the medicines and gets very low prices, but will only offer them to countries or programs that are ready to take on treatment in a reasonable way. But if they're not ready right then to take on the treatment, we'll offer the technical assistance. Collaboration among all the major organizations, that's going to be difficult. In putting together our Greenlight Committee, we benefited from anonymity. No one thought that this was an interesting or valuable football to play with. And a Greenlight Committee around HIV, is going to suffer from lots of people trying to claim their turf. I would just say to both WHO and World Bank that we have to prevent that from happening. By far the most important thing, though, is we have to make clear the nature of the moral challenge. It's been outlined so clearly and poignantly today by Jeff Sachs and also by our WHO and World Bank representatives. But the last slide, the title of my talk is "We Could Have Done More." Could I have the next slide? Last slide. Al Gore, when he was less busy, argued that in the first 10 years of this century, more people will die of HIV than all the people in all the wars of the last century. We are facing a moral crisis of epic proportions. And all of us, even those of us who are in the health sector, we are going to have to face our children in 10, 15, 20 years. And they're going to ask us, as German young people ask their parents, what did you do when you found out? Last slide, please. One of my favorite quotes, if you remember Oskar Schindler at the end of the movie Schindler's List, when they came to thank him, his response was, I could have done more. And all of us, even those of us who are terribly involved in this crisis, are going to ask ourselves that very question in 10 years if we don't get these drugs into the hands of people and start curing these patients immediately. Thank you.
Next, we have Ochoro Otunu, who's again from the Africa AIDS Initiative, a non-governmental group.
Well, thank you very much. I'm very happy to be here, delighted, and quite honored to be sharing this podium with very distinguished people who have contributed enormously to the fight against AIDS. I thought what I would confine my remarks to in the 7 minutes allotted to me is simply to focus narrowly on the issue of what I would call the political structure of the AIDS epidemic. If you look back to the beginning of the AIDS epidemic in this country and globally, in Africa, said in 1982, Uganda was the only country in Africa that had a prevalence rate of over 2%. No other African country had a prevalence rate of beyond 2%. And of course, Uganda was at the epicenter of the AIDS epidemic in Africa, because it started around the Great Lakes region, and then it radiated from there. If you move forward to 1988, and you look at the first WHO statistics on AIDS globally, you find that the figure would show something about 89,000 AIDS patients in America, and it drops to about 69 in Europe, and about 19,000 in the whole of Africa. That is 1988. Now, you move forward to the present time, Africa being the population or accounting for 10% of the world population, the whole of sub-Saharan Africa, it now accounts for over 72% of the AIDS incidents. And 95% of the AIDS orphans do live in Africa, out of a total of about 12 million or so, are orphans. Now, if you look, the question that we should ask ourselves, what happened in those intervening years of less than maybe 15 years or so? While the reverse has happened here, last year, I believe that last year the infection rate here was, I think, 40,000 people in the US. In Africa, 4 million were infected with HIV in Africa alone. The infection rate has been dropping constantly in America and in Europe, while it has exploded in all of Africa. And if we look at the response by the African countries, you find, of course, that a host of reasons why the African governments did not respond effectively and timely. It included, in terms, of course, political incompetence. It included the breakdown of the healthcare system in Africa, political upheaval, the lack of financing, but certainly also because of the taboo associated with sex and AIDS. What happened here in this country accidentally in the 60s was wonderful for Europe and for America. That was the sexual revolution of the 60s. For the first time, people could speak openly about sex and about family planning and about the use of family planning. In Africa, the opposite happened. That never took place. Now, in a society which is traditional and conservative, where no one talks about sex, and you find an epidemic that is related directly to sex, no one talks about it in the open. And the only fight against AIDS is about openness, fighting the stigma associated with it, and talking publicly about it. In Africa, this could not happen. And above all, in this country with the infrastructure, the information infrastructure, the healthcare system, you could confront the epidemic earlier on and very effectively. In Africa, the infrastructure did not exist, and worse still, nobody could use the protection that you take for granted here, the use of condoms. Because that revolution that happened here in the 60s never happened in Africa. So when I do hear people talk about what happened in Africa, we should bear in mind what happened here in the 60s. And that would go a long way to explaining why the AIDS epidemic has been so potent and so deadly in Africa compared to here and in Europe. But the failure of the African government cannot, of course, be excused. Uganda is a point in, a case in point where a relatively poor country mobilized. And if you look in terms of the Uganda response to the AIDS epidemic, it was not comprehensive at first. What happened and what was very critical in Uganda was a certain commitment to an open policy about AIDS. People could talk about it, politicians could openly go and campaign about it, and people work hard to take away the stigma that was associated with AIDS patients. That, to me, was the single most effective campaign against AIDS in Africa. And of course, Uganda has been talked about as the success story in Africa and globally, which is quite true. But Uganda is also a case of failure. Because if you look at about 1988, the incident in Uganda was about 15% of the population in terms of the adult population being HIV positive. The numbers dropped now to about 8%, which is what is called a success story. But the incidence of infection is still going on. What we can learn from Uganda is a certain openness and commitment to fighting the AIDS epidemic openly and effectively. But Uganda also had something that actually other African countries have not had. If you look at the AIDS expenditure in Uganda, about 70% of the expenditure is actually subsidized from outside, from WHO, the World Bank, and outside. Most African countries have not been that fortunate. They could barely raise 2-3 million to fight the AIDS epidemic. Uganda was very fortunate, partly because of the number of accidents. One, because Uganda was one of the first African countries to openly admit that there is AIDS crisis much earlier on. Other African countries did not respond immediately because of fear that they might scare away investment, tourism, and a host of other reasons. Uganda was different, and Uganda was the beneficiary of that openness. So when one talks about replicating what happens in Uganda elsewhere, we must also ask and confront the very important question, how will you finance it? How will you fund it? And I think that's been part of that debate. But in addition to the response by the African countries, I think one of the biggest failure was the failure of the international community to respond timely and effectively to the AIDS crisis in Africa. And I think I want to suggest to you that happened for two reasons. One was a lack of commitment. And that goes back to, I think, what has been said by Mr. Hansen very, correctly, and from WHO. We look at two World Banks. The World Bank of 10 years ago, that was derelict, that had no commitment. 4 years ago, I'll move it to 4 years ago. That had very little commitment to Africa. The World Bank that insisted on structural adjustment program, which decimated the African healthcare system. The World Bank that could barely spend anything on the infrastructure development in Africa. And I think the World Bank and the IMF played a big role in the expansion, the explosion of the AIDS epidemic in Africa. So I am very heartened, and we were talking earlier on, that I now see a new World Bank, which is much more committed, very vigorous, at the very forefront of fighting the AIDS epidemic, with a recent commitment of over 500 million, which is a very serious commitment, and expenditure of over 1 billion, as you said, globally. And I do mean it on all seriousness. We see a new World Bank, which I'm very heartened by it. But what the World Bank has not done, and what the WHO has not done, and what the international agencies have not done, is a particular mistake that made AIDS so dangerous and deadly in Africa, which is what I call the state-based response to crisis in Africa. The first actor, the prime mover in Africa, is always the state. When there is a crisis, you go to the state. But in the particular case of Africa, the deepest failing of all has been the state in Africa. Either it is too weak, it is at war, has collapsed, is corrupt, and it is incompetent. Now we go back to the same structure, the same instrument, the same organ that made it possible for the AIDS epidemic to become so deadly in Africa. But I think that is the paradigm that has not changed. In terms of the WHO, the World Bank, the UN AIDS, the World Bank certainly has made a big move forward, and I think WHO as well. In terms of insisting on funding for NGOs and community-based organizations, I think that's a very positive move. But as long as we insist that the prime mover, the most important organ to respond to the crisis has got to be the state, in a continent where the state has collapsed, that's the big mistake. Now, one example which I want to talk about very briefly, and perhaps the rest we can pick up on later on. Take, for example, the highly indebted poor countries, the debt forgiveness for that, which is a wonderful example, Jubilee 2000, I'm all for it. But if you look carefully, have you ever heard a prescription being given that a poor country that spends 30% of its budget on the military will not be funded? I've never seen that as a major criteria of it. How do you talk about a country that claims to be poor and spend about 30-40% of its budget on the military? That ought to be part of the criteria. How do you then forgive the debt of a country that, if you look at its national budget, has made no commitment to fighting AIDS? I think there have got to be certain conditionalities, certainly, which are constructive in nature. So if you spend a certain amount of money on your military budget, you will not qualify for that forgiveness. If you do not make a serious commitment to fighting AIDS, you will not qualify. But that comes to the very same paradigm that whenever you talk about Africa, whenever you do anything in Africa, responding to crisis in Africa, you must first go to the state, and the state is the major actor. A good example is in the World Bank $500 million commitment to Africa, which I think is wonderful and quite effective. One of the conditions, and you said it very well, has got to be the state has got to come and formulate a national policy on AIDS, which is wonderful because the state is the major mover. But the state also mediates at some response in terms of who the other actors are, who become the beneficiaries of the money that the state actually gets. And that is simply susceptible to patronage, to corruption. And in some instances, it's simply the transference of budget, whereby if the country is going to give 2 million to AIDS, and it gets 2 million from the World Bank, you move the 2 million earlier on to some other project, which is not susceptible to being monitored, to openness and transparency. So what I'm saying in terms of the response that has come from the international community, there has been a major shift and a major step forward by the World Bank, the WHO, the UN AIDS, which is wonderful and is truly welcome. But so long as we insist on the old paradigm, which we used in the development since the 50s and the 60s in Africa, to know really, and if you look at the billions of dollars spent in Africa, Africa is not developed. And we're in true danger of spending billions again in trying to fight AIDS in Africa, using the wrong paradigm, and 10 years later we'll be sitting here saying, what went wrong, despite all this commitment? So I think we need to look at how do we decentralize the role of the state, and how do we respond in a very comprehensive way, namely, how do we take care of the 10 million orphans in Africa? Is that going to be the lost generation of Africa? Or can we be effective in fighting that? So those are the set of issues that I hope when we get time we can at least talk about it. the role of the state, the response by the international community, and how we can formulate a comprehensive and hopefully constructive approach to the AIDS epidemic in Africa. Thank you.
I just want to say briefly before we turn to questions and answers that I do this all the time. I run the Carr Center for Human Rights, and we have events every day. We have lunches, and we have panels, and we have conferences. And this is one of the most extraordinary events that I've really been a part of. And I just want to hand it to the panelists. I think it's a combination of the gravity of the crime, as it were, the gravity of the epidemic, and the expertise and the concrete prescriptions that each of you have gone out of your way to offer. But it's also a lack of shyness, I think, about moral commitment and outrage, and I think that's a really important piece of this. Speaking of moral commitment, I'd like to introduce Adam Taylor from the Boston Global Action Network, who'd just like to make a brief plug.
Thank you. First, I'd like to thank the panel, one, for their sense of urgency that they conveyed, and also the sense of hope, because I believe that we cannot lose hope in this pandemic. I also want to say that we are currently sitting on the eve of World AIDS Day, in which millions of people around the world, billions of people, will be standing in solidarity with people who are both infected and affected, which is all of us, by the HIV epidemic. I hope that no one leaves tonight feeling overwhelmed or feeling paralyzed by the concern and guilt that they feel. I hope that it leads to some kind of action. And I am asking for two challenges to everyone. One is the Global Action Network is sponsoring a breakout session after this event to talk about how you personally can get involved to make a difference in this pandemic. And so we're going to meet in L150. I hope that some of you can stay. I know it's been a long night, but if there's one sacrifice that you make this year, I hope it's this one, to really recognize your ability to make a difference in this pandemic. The second challenge and plea is one on the drug pricing issue. Pfizer, which has an office conveniently located down the river from us, is the only producer of fluconazole, which treats two opportunistic infections that cost the lives of about 3 to 4 million people each year in Africa. Currently, those prices are kept at an artificially high level for the benefit of corporate greed. And we have a rally tomorrow and a vigil at the footsteps, or the lawn of Pfizer, which is located at 620 Memorial Drive. This is a collaboration between Harvard, MIT, Boston University, as well as other members of the Boston community. There's a pre-rally for people here at Harvard at 3 o'clock here in the forum, and we hope that you get more, we can give you more information about that issue. That said, I do have a quick question.
Okay, before you do, I just want to give the rules for the questions. Because we're running so low on time and because we have so many questions, we want to keep the answers, if we could, to less than a minute. Really. And if the questioner could direct his or her question directly to one of the panelists, that would be terrific. And also identify yourself. You don't have to.
Okay, thank you. My question is mainly for Dr. Kim and for our World Bank representative. I just talked about the patent regime and drug monopoly that many pharmaceuticals have on drug prices. And I wonder, coming from a position of an activist, someone who believes that something can be done on this issue, what would you advise in terms of mobilizing people, whether it's consumers, because I think drug companies are at the beckoning call of consumer dollars, or other strategies to try to lower the prices of drugs that we know can be affordable to save lives in Africa?
Dr. Kim, what?
I would say, first of all, going to rallies like that is great, right? Now, the comment that you make is drop the patent, drop the prices. Now, you know, we have to, I wrote a book called Dying for Growth, a critique of neoliberalism. But as a physician working very closely with poor people, you have to think, is dropping all the patents really going to be good in the long run? Let's look at a disease like tuberculosis. There is no financial incentive to make drugs for tuberculosis, and there have been no drugs for 30 years. And right now, trying to develop new drugs for tuberculosis, the Gates Foundation and Rockefeller have put $40 million into it, but I don't know if we're going to have a new one in the next 5 to 10 years, because there's absolutely no financial incentive to do it. So I think we have to think really carefully. I think you guys, when ACT UP went and took over the Pfizer building in New York City, it had a direct impact. Now, ACT UP was hitting with a bludgeon. They weren't talking about the intricacies of new drug development for infectious diseases, but the fact that they did that is what allowed many others to really negotiate the lower prices for South Africa. Now, they haven't been delivered yet, and so perhaps, and I'm not suggesting anything, perhaps they need to go back and take over that building again. but what I would say is that, talk to us infectious disease nerds. We will tell you, go ahead and do that because you need to put pressure. And then it may turn out that what we need to do is get them to give us one at market price so that it keeps their incentive up in the first world countries. Because I don't think it's any problem for me, for first world countries to pay higher prices for drugs to subsidize the poor. I think that's fine. So you get them to give you one at the market price and then donate 9 others. They get a tax deduction, they keep their market prices. That may be the best strategy, but I wouldn't say that to you. I'd say that, for you, it's sort of like tear everything down, and if you don't do something, we're going to tear it all down. So, this is public though, isn't it? Sorry. This is sort of an inside strategy session, and that's what I would really very directly suggest.
Okay, let's just move to the next question over here. Identify yourself and direct it toward our panelists.
Yes, my name is Eric. I'm from the Kennedy School. I'm also from Haiti. The epidemic from Haiti is very similar to Africa. We have about 30,000 new infections a year. And we modeled the epidemic, estimated the socioeconomic impact of HIV AIDS, the orphans, etc., and we presented that to the donors, including a budget of about $4 million. And the donors didn't do anything. And the World Bank, I believe, provided maybe $800,000, and I don't even think that it was a gift. It was a loan. So what else do we need to do to motivate the donors? And one last comment about Uganda. With the prevalence rising in Thailand, I'm not worried that the same thing will happen in Uganda, that the prevalence will rise again?
Keith, do you want to handle the first part of the question? And then Choro?
Keep turning the heat up on the donors to support this. We need more money, we need more support. If there's a good program in place, it deserves support. There should be adequate money available for this. It's true, the bank money does not come free. It does come heavily subsidized, and that's not our choice. This is how the money is given to us, but we pass it on at about 65% grant on every dollar. But I mean, you should have a multitude of sources. The bank is only one provider. There should be others who come in, and I'd say just keep at it. I mean, there's much more interest now. We've just put together a similar program in the Caribbean to the one I described in Africa. Other donors are more interested. The U.S. is putting in more money. Now is the time. And my worry, frankly, is that this swell of support and interest is going to crest and then disappear, and we'll move on to the next crisis in a year. So we've got to take advantage now.
Are there questions upstairs?
Yes.
One upstairs, please.
Hi, my name is Susan Misra. I'm a Kennedy School student. This is for the World Bank representative. I would like to know what kind of work is being done to coordinate or to correct for inconsistencies between the IMF structural adjustment policies and the World Bank loans, even with their conditionalities that are trying to help healthcare. For instance, I know that Tanzania is currently being considered for a policy that will continue user fees for healthcare in that system, and we do know that when user fees were implemented in Tanzania, it caused a much lower attendance at hospitals and other healthcare institutions.
This is a huge topic that could take up another 2 hours all by itself. The short answer is that adjustment programs, first of all, are not what they were 4 years ago either. There's a great deal more attention to ownership and to sensitivity in these things. User fees is a very difficult issue, actually. It's not cut and dried. There are definitely cases where they have hurt, but there are plenty of clinics in Africa where care is free and there is no care because it's free and because the community has no control. It's not paying for anything. It has no control over what happens. The goal certainly is never to keep anybody away. And there is no point, there's no way at this point that we are going to do anything in any of our programs that impedes the effort against HIV/AIDS. I can't, in a minute, I can't do justice to that big topic. It's a very serious one, and a lot of work is going into it, and we are definitely aware of it.
Great, thank you. Sir?
Okay, my name is Basil Enwebara. I'm a student at MIT. My question should be, couldn't we come to a conclusion or start imagining that something is wrong with African AIDS? Because if a country that had a few years ago a few thousands of AIDS today has millions, can't one start imagining, start conceptualizing that probably, let's see, for example, company like oil, a share company in Nigeria, couldn't it be interested in helping communities to have this AIDS? Or I'm sorry, I might be very radical in my discussion. What about in Zimbabwe, for example, where the whites are having problem with lands. So what I'm trying to argue is that we have to look at the interests of multinational companies that started in Africa in 1436 that has never come to an end. Anything takes place as far as it's Africa, and people have to look into these issues of the interests of multinationals because they could help to spread these aids for corporate interest and for political instability. And we have to look into this because a lot of things take place in Africa and nobody knows. We come up with a lot of fancy figures, but we don't know actually what takes place in Africa. Thank you very much.
Who would you like to respond?
Nobody could respond. Thank you.
Achora, do you?
Well, my response is you're of course right, and I think one of the problems with AIDS in Africa has been the huge colonial legacy that Africa has been having to deal with. Namely, there's a certain resistance to help from outside, of suggestion from outside, because time and again history has shown that when people come to Africa, they don't always act in the best interest of Africa. And that has been part of the issue. It may have actually well been part of Thabo Mbeki's response. And so that has got to be taken into consideration. Yeah.
Okay.
And very quickly, for Uganda, vigilance. You compare Uganda with Thailand, more vigilance, more voluntary counseling and testing, and more availability of the use of condoms. That has got to continue, that way. Thank you.
Thank you. Yes, ma'am.
My name is Nava Ashraf. I'm a PhD student in economics and government here. I have worked a lot in Africa and seen a lot of colleagues and friends die because of AIDS. To follow up on that, I had one question and then a very specific question. What is it particularly about Africa that has made the spread of AIDS so quickly there, and it's so much stronger than in other countries? It doesn't sort of, if it's poverty that exists other places, is it culture? In trying to find the best prevention, we need to have a better understanding of what causes. So,
Who would you refer the question to?
I'm not sure actually. So anyone who has
you
comments.
sort of responded to that.
Yeah.
Okay, both of you then.
So sorry, go on.
Okay.
Well, I was just going to say maybe I suggest two very quickly and then I leave it. One certainly has been the poor healthcare infrastructure. So you don't get the early counseling treatment of STDs the way you get it here. And there's a certain correlation between the infection rate and STD. The other issue, certainly as I mentioned, is the question of the use of condoms in a traditional setting. And that has been proven to be one of the most effective ways of stopping the spread of this illness. And maybe the final part about it in Africa has been certainly the lack of the information infrastructure. In order to combat the AIDS epidemic effectively, you need to communicate. And where you don't have access to radio, to television, to print media, it makes it very difficult.
Jim, a quickie, and then we're going to go to Naomi.
First of all, I want to say a couple of things. We did a study, especially looking at Haiti, but we published a book called Women, Poverty, and AIDS, where we looked at this question very carefully. And the conclusions in Haiti and many other places were it's really inequality. Because the women in Thailand who are getting infected are on an absolute level much wealthier than the women, say, in Haiti who we work with. But the grades of inequality had a lot to do with it. Now, just for the record, I think I was really moved by Keith's presentation, but we have to be honest about where the bank was. In '92, the bank published a statement that said, well, with the population decreases that we're going to see in Africa, that could really increase GDP per capita, right? And no one could believe that they actually wrote that, but that's in a World Bank document. The other thing is that in 1996, Peter Lurie wrote an article about the impact of structural adjustment programs on AIDS in Africa. And he argued that structural adjustment programs directly contributed to the rise in incidence of HIV, and for many different reasons. The response of the bank at that time, Richard Feacham, who was a senior advisor in health, was, well, Dr. Lurie's objection is not with HIV or with structural adjustment. His objection is with development as a whole. Surely, if we go back to the Stone Age, that will stop the transmission of HIV. It's in the British Journal of AIDS. You should all get it, because it is an indication 4 years ago of where the bank was. I think that the transformation of the bank with President Wolfenson and the remarks that we heard tonight is among the most important things, because the bank is going to be the organization, I think, that helps us to begin solving this problem. But I would say that it's not mysterious. In Haiti, for the first 5 years of the epidemic in Haiti, there were all these conjectures about what went on. And one of the things that we heard was that Haitians are at risk for HIV, but it's because of their culture. It's voodoo, and it's because they have sex with monkeys. There are no monkeys in Haiti, okay? And this stuff appeared in scientific journals, all right? So I think that the last thing that we need to do is to mystify and exoticize Africa, to think about what's special about it. India, the incidence of HIV is going like this. In the former Soviet Union, the number of cases recorded last year is more than in all the years previous. It is happening everywhere. This is not something mysterious and unique to Africa.
Naomi, a quick...
No, I just wanted to add that the WHO published a report in 1996 talking about the burden of disease in the African continent. So you can assume that the HIV was coming into explosion in the midst of already the burden of disease. And the health systems, the health sector itself was already caving in and not capable of coping. So the mortality rate is rapid and fast than any other situation, in the sense that the environment in itself in which the HIV is manifesting itself is already weak, and it is rife for such huge incidents to take place.
Thank you. Okay, I think is there another one upstairs?
Yes. My name is Akin Jimo. A lot of funds is going to Africa now, and quite recently there were some reports that a number of countries were part of the most corrupt nations in the world. I'm looking at a situation whereby policy instability is there, implementing is not effective in the past. Now with 500 million going to Africa, $25 million going to AIDS work in Nigeria, is there any thought about monitoring and more or less keeping track of that these funds really get to the communities and the individuals that need assistance? Thank you.
Any of you want to take this?
Yes, absolutely. That's why we put such an emphasis on having a broad group of stakeholders who sit on the AIDS committees that administer the overall program. It's not just government people, it's not just people in the national AIDS control programs, it's people from civil society, the private sector, other ministries, watchdogs, if you will, but also implementers. And the money that goes to communities, depending on the country and the degree of confidence in the system, that money may be completely sort of immunized through regular systems and have its own channel, its own account, et cetera, not even out of fear of corruption, but simply out of fear of the usual sluggishness of bureaucratic procedures to get the money there. The goal is to get it to communities as quickly, safely, and accountably as possible. And whatever the relevant situation is in the country, that's what we're focusing on. And a very heavy emphasis on monitoring and evaluation. Very heavy, and a large amount of money going into that, because we just don't know enough about many of these things.
I think that is extremely important. This is the new face of the World Bank, and I think it's extremely encouraging, because what is really happening now, and I was trying to demonstrate that there's a gap between the policies and the realities of what is happening. And if you are talking of supporting the communities, then this kind of system that is being put in place, I'm not speaking as WHO here, so that don't quote me, that we need this, we need to push this down fast, because really the support to the communities is not reaching there quickly, so that the response and the capacity of the community to reduce the spread, the quick spread, is still very, very limited, and the community is still very, very vulnerable, and this is not WHO.
Thank you. Yes.
Okay, I'm from Harvard School of Public Health, and I have a question for Naomi. Given the lesson we are learning from the AIDS crisis in Africa, I would like to know if the WHO has developed a set of strategies or prevention framework to prevent a similar crisis from repeating itself in other regions of the world, such as China. I know there's a potential crisis there. China, India, Pakistan. Thank you.
WHO has come up, I think at the beginning of the year or last year, has come up with an HIV AIDS strategy. And a part of that is really a major emphasis of preventing, particularly in the regions where the HIV AIDS is not as, where we don't have a high prevalence. Yes, they are working very hard, including in Africa. We talk about the 7 states of Southern Africa, but we are also working very hard to make sure that the spread, the HIV AIDS spread doesn't become as prevalent in northern states which are not as highly infected as the Southern Africa. Yes, in all the global, yes, WHO has a global policy on that.
I think we're only going to have time for 2 more questions, you, sir, and then we'll come back and do another one here.
Yes, during the last decade, Africa has been going through a process of democratization, and many of the countries there are in the process of transition to democracy. What impact do you think HIV/AIDS will have on the process of transition to democracy itself and on the process of governance within countries? It's to really anyone who wishes to pick the question up.
My response will be one negative, one positive. The positive impact would be, if you look at, as I said, the incident out, the trajectory of the AIDS epidemic in Africa, it goes to show that there should be a strong emphasis on good governance. Because that's the only way you can ensure that, the state is there, is responsive, that it delivers the social welfare system. And the second, of course, is to put the emphasis that you need to decentralize the state, that the state is not the one that mediates everything in society, that if the state fails, there are no other actors in place. So we need to emphasize more the presence of civic society, NGOs, grassroots organization, as alternative delivery system to the state. On the negative side, of course, the HIV is killing up some of the cadres, the people who are well-trained, the elite. And so you are having gaps simply from the university system to civil service, to the people who should be implementing. So the human capital itself is being destroyed. And that impact will be felt down the line. And that's one of the biggest challenge to Africa. How do you replenish and how do you train the younger generation? And yet, especially that's the generation that's dying off very quickly, the 15 to 49 years of age. And that is going to have a major impact, on Africa, unless right now we make a strong commitment to human capital development in Africa.
And our final question of the evening is appropriately one that is the product of a caucus between the 3 people who were standing at the microphone.
Oh yes, I had to negotiate.
To the collaborative spirit.
I had to negotiate. I'm also paying this commission after.
Please.
And the reason I had to work so hard to get here is because I am from Southern Africa. And I thought it was integral that I voice my opinion and make a contribution, to the forum. I have obviously brothers, sisters, and cousins that die next to me that have died, in hundreds, and thousands, of course. And I really would like to get to the point, or at least approach this more from a psychology, social psychology, and more communication aspect, because living in that kind of an environment, I think the stigma is actually what is working against us right now, I come from a pretty, say first class, family back home, and to be honest with you, I think what most of us and my friends and my generation would normally talk about, would have problems about, which I think to answer the lady who asked the question as to why it's spreading so fast, is because we're so scared of it. I think my brother from Uganda spoke about a sexual revolution where the Western world obviously started speaking more about it and so on. And I think that really has been what our problem. That there's a stigma around it, and that people, obviously when there's a stigma associated with it, is we think we're going to die and so on and so forth. And to be honest with you, very few people actually know, well, I'll say mostly those are unaffected, perhaps do know that there are drugs out there available, to treat the opportunistic, I actually didn't know until I actually got here, and I come from a pretty, decent family, and because of that, it actually causes a psychological problem because you think you're going to die. So what happens is you're so afraid to go and test, and you're even afraid to talk to your friends about it, So the point that I'm trying to make is that, and to prove my point, is that there was a woman in Durban in South Africa who actually who was killed just about a year ago because she actually went out and started speaking about AIDS, publicly and so on, and she got killed just for talking about it. That should give you an impression of how serious this is, as in a village, in a community. And and I think that's more perhaps maybe from a preventative, as in before the actual infection stage, as to why it's actually, causing, this ripple effect. It's because we're not talking about it. And I think after a person is actually infected, I think the problem there too is obviously you lose hope. I think a bigger part of treating this problem is more of a communication, is more of a psychological problem. When you think that you could perhaps get treatment or perhaps, perhaps could survive, you change the way you live your life. In terms of you go and exercise, you wake up and you do something about it. I think once a person is infected back home, they think that they're going to die. So something, they might as well either, infect more people, or they might as well, die. So there's a huge social psychology, behind this, and I think needs to be addressed. And I think that is actually where my question is going to be directed in terms of how far are you actually working with the PR organizations, the communication, specialists, because they form an integral part of this. And if of course there is, and if there was perhaps a greater, communication, model in place, obviously you'd get more people tested because they would know that if I test earlier, I have more chances of surviving. If people got to know the information that the drugs were available and so on, they would pressure the governments to perhaps to be more transparent and so on and so forth. If the people knew about it, so the communication aspect of it is very important.
Who would you like to respond to that one?
I think whoever it is, it'll be great.
Great. Why don't we give a few the panelists start, Jim, and then
quickly. I would say the questioner makes an extremely good point. That if we offer effective therapy for everyone in Africa, the dynamics of prevention will change, right? And I think that Professor Sachs put it perfectly. To offer prevention without treatment is obscene. I totally agree. And I think that it will make prevention more effective. That's all I'd say. And we need to start understanding that and getting that message out. Public relations companies, anyway.
Yeah, in the case of Uganda, is to make this point, that there's a very strong correlation that they found between voluntary counseling and treatment. You don't want to go and be, tested if you don't know that there's actually treatment later on. And that has been very effective in Uganda in terms of changing the behavioral pattern. That the age of, sexual, activity has actually gone down. You find that women actually were between 14 and 29. The rate of infection has gone down, aggressively because of that. So just, to say, you can't talk about, prevention without treatment. It just doesn't work.
Keith or Naomi?
I just wanted to say that I think the World Health Organization has been now working a little bit more on the treatment. And I'm pretty sure, I think you see the change that you are asking for, because where the treatment has proven, where it has been effective, like where those the patients were almost like written off and they have beginning to resuscitate. There's now a lot of hope, and the people are really coming up a little bit more. Yes, it's an African culture. We have problems of communications. I think we have a communication in all the 46 countries. The World Health Organization has communication office, and we work with the other UN partners. That is going on, but it is difficult.
Well, please join me in thanking the panelists and thanking the forum for this event.